Good morning, good afternoon, good evening. Thank you for joining us today. Before we get started, just a few technical announcements. This meeting is in French and English. To listen to the French audio, click Interpretation and select French. To hear the French only, click Mute Original Audio. Cette réunion est en français et en anglais. Pour écouter l'audio en français, cliquez sur Interprétation et sélectionnez Français. Pour n'entendre que le français, cliquez sur Couper le son d'origine. Please feel free to introduce yourself in the chat box. We ask that you remain on mute while others are speaking. And during the discussion, you're welcome to raise your hand using the Zoom function on the bottom of your screen and ask your question directly. The recording and presentation slides from this meeting will be sent via email to all participants and will be available on the Child Health Task Force website. Feel free to message me on Zoom if you have any technical difficulties during the webinar. All right, and with that, I will hand over to Martin.
Thank you very much, Sita, and good morning, good afternoon, and good evening, everyone. Thank you very much for joining this webinar on providing respectful care for newborns and children, lessons learned and opportunities for improved experience of care in healthcare settings. Next slide, please. So briefly, just the session plan for this webinar. First, we will have an overview of newborn health context and policy background in Kenya. This will be followed by an overview of study and key research findings. Then we will hear about the Respectful Maternity Charter, a framework to support healthcare workers and empower care seekers to demand respectful care. And then we will have time for some questions and answers. And finally, some closing remarks. So next slide, please. This webinar is presented jointly by the Quality of Care Network. The Quality of Care Network for improving maternal, newborn, and child health. It's a broad partnership of committed governance, implementing partners and funding agency working to ensure that every pregnant woman, newborn, and child receives good quality care with equity and dignity. As you can see on the slide, there are 10 countries involved in this network, 9 in the African region, and then Bangladesh and India. Now, the overall goal of the network is to halve maternal and newborn mortality in specific health facilities in the network countries, as well as stillbirth, and also improve the experience of care. To achieve this, the network has set 4 strategic objectives, which are leadership, action, learning, and accountability, sometimes referred to as the LALA strategy. For more information, you can visit the website, which is also down on the slide. Next slide, please. So as I said, this is done jointly with the Child Health Task Force. The Child Health Task Force has over 2,600 members from more than 80 countries and over 300 organizations. These people are working together in 10 different subgroups, focused on 5 themes of work. So one is coordination, which is to foster organization collaboration at global and country level in support and comprehensive child programs. Then also around advocacy, to advocate for integrated package and increased financing of child health programs within the primary health care. Then the support to countries is basically to implement effective and comprehensive child health programs to achieve effective coverage and impact at scale. The learning component is to promote implementation science, advance innovations, and engender the use of research results to inform program design and implementation. And then finally, around the knowledge management, which is to build evidence on comprehensive child health programming and make sure publicly accessible, especially to child health stakeholders. And as you can see, the overall goal is to create a platform in the child health community to advocate for and provide targeted support to countries to improve quality of care for children in countries where task force members are active. You can review and suggest subgroup activities by clicking on the link in the mid-right section on the page. And also recordings and materials from past meetings and webinars are also available on the website. So next slide, please. So today's panelist, we are happy to introduce Dr. Caroline Mwangi, Head of Division at the Neonatal and Child Health in the Ministry of Health in Kenya. Then we have Dr. Charlotte Warren, Senior Research Associate, the Maternal and Newborn Health Population Council. We have Chantal Okondo, the Program Officer at the Population Council Kenya. And then Elena Atewa, who is the Advocacy Manager at White Ribbon Alliance. Next slide, please. And then the webinar will be moderated, and also the questions and answers sections by Dr. Felicitas Makoka Okwago, a consultant pediatrician and Kenya Pediatric Association member. With that, I would like to hand over to Caroline Mwangi. Thank you very much.
Thank you. Thank you for that introduction. So I'll take you through my presentation, the newborn health context and policy background in Kenya. Next slide, please. So globally, we know child survival remains an urgent concern, and that the first month of life is where children face the highest risk of dying, at a global rate of 18 deaths per 1,000 live births. And a third of these neonatal deaths occur on the day of birth, and close to 3/4 in the first weeks of life. In Kenya, the leading causes of neonatal mortality are intrapartum related birth events, birth asphyxia. The second leading cause is prematurity. The third is sepsis. And we do take note that majority of newborn babies are born and attended to at public health facilities in Kenya. Next slide. So if we look at our situational analysis as a country, according to our Kenyan Demographic and Health Survey of 2014, we had a neonatal mortality rate of 22 with a slow but steady decline from 26. The under 5 and the infant mortality has seen a considerable decline, with the table showing the recent UN estimates, currently with a neonatal mortality rate of 21 and under 5 mortality rate of 43. Next slide, please. So in Kenya, as a newborn program, we've developed guidelines, clinical care guidelines, as shown. We have kangaroo mother care training guidelines, the integrated management of newborn and childhood illnesses, the comprehensive newborn care protocols for the 3 levels of care. We do appreciate that newborns are seen at these 3 levels, the primary, the secondary, and the tertiary levels, and also the care for child development guidelines, which outlines training for caregivers and also for healthcare workers. Next slide. So a little bit about our policy framework. 2018, the Neonatal Child and Adolescent Health Policy was released. This gives a framework for implementation of low-cost, high-impact interventions to reduce neonatal and child mortality. The nurturing care framework was adopted in 2018 by the country, and we've managed to integrate the nurturing care framework into guidelines and tools. Ongoing is finalization of the early childhood development policy and strategy, advocacy strategy for implementation of the nurturing care framework. Next slide. So a little bit about quality of care. As has been shown, Kenya is a member of the Quality of Care Network. We joined it in 2018 and subsequently developed the maternal, neonatal, child health quality of care. And it is anchored amongst on this framework. Next slide. So as a division of neonatal and child health, there is ongoing adaptation of the World Health Organization standards of providing quality care to small and sick babies and sick children. So I'd like to highlight 2 particular standards that are relevant to today's topic of discussion. And we hope that as a country, once finalized and integrated into our quality model for health, that's the EKQMH, we will entrench and ensure that newborns, small and sick babies and children are managed at the highest quality of care standards. So the standard 5, newborn rights are respected, protected, and fulfilled without discrimination, with preservation of dignity at all times, in all settings during care, transport, and follow-up. And standard 6 also talks about small and sick newborns are provided with family-centered developmental supportive care and follow-up, and their families receive emotional and psychological support that is sensitive to their needs and strengthens their capability. So we hope as a country we can adapt this and implement it. Next. So as I conclude, thank you for this opportunity. I'd now like to invite Dr. Charlotte Warren to present her study. Thank you.
Good day, everyone. My name is Charlotte Warren, and I lead the Maternal Newborn Health Portfolio for Population Council, and I'm presenting this with my colleague Chantal Okondo. This work is supported by USAID through the Council's Breakthrough Research Project. Next. This is just to show our presentation outline. Next. Although there is a growing body of knowledge and interventions to measure and mitigate mistreatment of women during facility-based childbirth, there is actually very little evidence of the experience of hospitalized newborns, infants, and young children up to 2 years, and that of their parents. We started with a literature review, and these two frameworks were critical in building our work on how to include parents caring for sick young children in a low-resource setting. Much of what we built on was specific to the experience of care component in the WHO quality of care framework and the nurturing care framework, which is highlighted there with some other components discussed by Altmira et al. Next. We had two overall objectives. The first was to understand the experience of care of sick newborns and young children up to 24 months and their parents in 5 hospital settings. And subsequently, we assessed the feasibility and effectiveness of a structural and provider behavior change intervention in 5 Kenyan hospitals. Next. This slide summarizes our overall approach and the key activities that took place between 2019 and 2022, earlier this year. And you can see where we collected data and introduced the interventions and various things. However, the COVID pandemic affected our the service provision in the facilities that we were working in. There was people were told to stay at home and were not seeking care. And it also affected our study design and our data collection plans. We were able to adapt our study design and methods, but we were constrained with regard to conducting face-to-face interviews with providers and parents, and also to visit the facility for follow-up facility visits. But we were able to make some changes and continue with the intervention. Next. So now I'm going to talk about a paper recently published a couple of months ago, led by Timothy Abuya in our Nairobi office, and it draws on the formative work and describes the manifestations, responses, and consequences of mistreatment of sick young infants and their parents. During the analysis, we looked at the typology of 7 overarching categories of mistreatment that was developed by Boren et al. For mistreatment of women during childbirth. And from these qualitative interviews with families and providers, examples of reported mistreatment fell into 5 categories, including a combined category. So the first one is combined from the Boren, the failure to meet professional standards and the health system's constraints. But we also had another one which we combined as physically inappropriate practices, which also includes inappropriate feeding practices and various forms of physical abuse. One other area not included in Boren's typology for childbearing women, but was added by Emma Sachs in her literature review of defining mistreatment of newborns, was around bereavement care, where we saw a lack of emotional support and counselling for parents. We subsequently grouped the examples of mistreatment into acquiescent and assertive measures after McMahon's paper. What we mean by acquiescent is that the non-confrontational methods, where parents often felt humiliated by the treatment from the providers and were resigned to how they were treated, hoping that their stay would be short, but they didn't say anything. And then the assertive methods, which were more confrontational in reaction to any mistreatment, these were much rarer, but they were observed when parents expressed disappointment or became angry with the providers. Next. We then looked at the pathways of mistreatment and potential consequences from the system and policy level drivers, which you can see in the box on the left, and then the individual drivers, then how they manifested in the young infants, which is the middle box, so like discrimination, rough handling, negligence, non-consented care, wrong diagnosis or crowded conditions. And then on the right-hand side, we have the temporal responses, again, looking at the acquiescent measures by parents, how they felt sad and stressed, remained quiet to avoid conflict. And then the assertive measures where parents would take their children home without medical advice and became angry. And these all had these long-term effects on the cycle of emotional distress of the parents and children and non-adherence to treatment. Next. So to address these issues, we focused on improving the experience of care for parents, children, and providers. I'll now hand over to Chantal to take us through the remaining slides.
Thank you, Charlotte. So just to kind of go through this slide briefly, the theory of change was developed from the formative research that Charlotte just presented, available literature and stakeholder discussions. And this was done through a co-creation workshop that had parents and providers that worked at these facilities. We also had health managers, professional associations, NGOs, and the Ministry of Health present. And during that co-creation workshop, we agreed that we would use nurturing and responsive care as a basis for introducing interventions that influence provider and parent behavior. So you can see at the bottom there, the orange bar that highlights the nurturing care elements that we looked at. So optimizing nutrition, protecting skin, minimizing stress and pain, safeguarding sleep, etc. I will talk on my next slide about the intervention inputs, but just to highlight another area, which is that we did have 3 levels of outcomes. So we had the health system environment, we had outcomes that focused on provider and parent interaction, and we also had outcomes that looked at improved newborn, infant, and toddler health, as well as informed parents, empowered parents, and reduced parental stress. Next slide. So just focusing more on the intervention inputs, how did we operationalize our theory of change? We did have an orientation package with quite a bit of different sessions, and we did this in a cascading way. As Charlotte mentioned, we were impacted by the COVID-19 pandemic. And so what we did was we trained an initial core of about 25 or more providers from each of the facilities that we worked in. And these providers were then tasked to introduce the intervention at their respective facilities. And so the intervention sessions were included the nurturing care elements. We also looked at organizational characteristics so that they could be able to work in an enabling environment. We also sought to unpack their values, beliefs, and attitudes. And we had sessions that also looked at communication, engagement, shared decision-making, and another session that also looked at emotional support for providers so that they could manage their stress and burnout. And so these providers, once they were trained, they had to go into the facility and coach and emotionally support parents. We had developed quite a few job aids, and although they were not translated into local language, we had job aids that focused on what we called like a DEP guide, so distress, emotional support, and partnership guide. And this was mainly tasked to help providers emotionally support parents. Providers also worked with mothers and fathers in terms of in the care and also for decision-making for sick young children. And we also used the same job aids to help them coach parents on nurturing and responsive care. We will share the links to the job aids throughout the course of the presentation. My last input was around the monitoring for structural change, and this focused on provider and parent feedback forms that we introduced. As well, we did have periodic meetings, most of them were virtual, all of them were virtual, where we sought to document changes that were happening in the facilities and identify additional solutions. Next slide. So my next few slides, I will focus on some of the findings from the Endline survey that we did. And while we had hoped to conduct quantitative checklists observing provider and parent interactions, we were unable to do so because of COVID-19. And so we were only able to quantify client perspectives through follow-up parent survey. And so I'm just going to present briefly on two indices here. So the communication quality and the respectful care. And we could see across the board that there were high levels on both of these indices. And under communication, quite a few parents reported that they had an introduction with the provider, there was some sort of dialogue, and the providers spoke to them in an understandable language. They were listened to and attentive to providers, and they gave follow-up instructions. Providers also were respectful, or parents reported them being respectful to their families and to hospitalized child. Just to highlight that one parent, a mother in a pediatric ward, she quite well put it very nicely, is that when they came to check up on your baby and you asked how the baby was progressing, even if they were doing tests on the child, they would stop to look at you and listen, then give you a response. Next slide. The other aspect that I want to highlight is that we had asked providers at baseline and endline their knowledge on nurturing care elements. And so we obviously had different aspects for a newborn and one for an older child, but across the board, we could see that there was significant improvement on providers' knowledge on nurturing care components. And qualitatively, we saw one nurse mentor, she's quite well put it that, you know, the kangaroo care before the training was known. However, the nurturing care was not very well known. And through the training and as well, her ability to mentor her colleagues, she was able to teach caregivers on how to communicate, aspects of sleep, as well as how to listen to parents. Next slide. The other aspect that I would like to speak about was the provider peer feedback. So under input 3, we could see here that there's varied interactions in terms of the nurturing care and responsive intervention aspects. And we found that especially under safeguarding sleep, minimizing stress and pain, and play and cognitive development were quite few. And one of the reasons for this was that providers had inadequate time. There was still the issue of low staffing. And then obviously the layout sometimes of the pediatric ward and the NBU resulted in like limited space to counsel parents. And sometimes, especially with the play and cognitive development, they lacked the supplies to interact with parents to do this aspect of nurturing care. Next slide. So as part of the end line, under the parent follow-up survey, we asked parents what type of information did they receive on nurturing care. And across, when you consider this by wards, there's a similar theme to follow. There's a similar theme that seems to follow, that elements of nurturing care appear to be less emphasized in the pediatric ward as compared to NBU. And this just could be because the nurturing care framework was initially designed or was initially introduced in the NBU. Although there are some high levels, such as under optimizing nutrition, minimizing stress, they had some, such as keeping the baby warm, changing diapers, and protecting skin, cleaning the baby. So next slide. So again, under input 3, when we look at what sort of structural changes happened for positive experience, just to remind you that we did have periodic meetings with providers where they talked about how the intervention was being implemented and what they were learning. And some of the changes that they had discussed or that was shared in these meetings included that some facilities reorganized feeding spaces and times to increase parental flexibility. And most of these features, just to highlight, they were low cost. So it was during COVID, so we did see improved hand washing stations with signage to promote hygiene. There was a use of baby-friendly colors and provision of toys to stimulate children in pediatric ward and others that you can see here. And qualitatively, what we did see was that having our mentors be part of the hospital management team was really important in terms of getting the resources to implement the intervention. And one nurse in our facility talks about, through our facility HMT, one of our mentors is a member. So when we have suggestions or we have proposals, she makes sure that they are passed in those meetings. That is a great enabler to intervention implementation. Next slide. So one of the outcomes that we did sort to look at was the parental empowerment. And we did see quite a high number of parents reported that they felt empowered. So 82% report scoring 23 out of 28 points. And you can see here below, it was a 7-item scale that we asked parents. And they featured things like, I feel in control of my newborn or young child's health. I will be responsive to and care for my newborn or young child at home. I can share information about caring for my newborn or young child with my family and friends. And so under this 7-item scale, there was between 1 to 4 questions under each of those items that resulted in 28 points. And again, qualitatively, we see a mother in the pediatric ward who very well says that, the child was not bonding with the father while he was not around during coaching. And she was the one who told him how he could bond with his child well. Next slide. When we did the regression model, we found that parents who received information during hospitalization on nurturing and responsive care also reported high levels, such as the ability to provide nurturing care, the interpersonal communication with providers, as well as the parent empowerment. And all this was significant. We did, for the regression analysis, we did control for the age of the child, the age of the parent, parental education, marital status, if the child had died, the length of hospitalization, separation of mother to baby. And so cross-sectionally, we saw associations that showed differences between parents who received information and those that did not receive information on nurturing care. Next slide. So what did we learn? Just briefly, I know I've gone through quite a bit, but just briefly. So we piloted a structural and behavioral change intervention, and we've seen that this is feasible to implement in a Kenyan setting. We saw that providing targeted intervention to providers is associated with parents' experience of care, interpersonal communication with providers, and as well as parents feeling empowered. There were significant differences between the newborn and the pediatric units. And this also is apparent in how parents received information and some parent-provider interaction outcomes. What we do want to highlight as well is that involving providers and managers in the intervention development and implementation is really important as part of sustainability, and including these aspects in the PDSA cycles and being able for providers to play an active role in how the intervention was implemented. A lot of what we introduced were low cost. And so what we do find is that there's promising program practices and things such as parent feedback forms. They can be institutionalized. Also, just due to we did work in a COVID-19, during the COVID-19 pandemic. And so using these mix of face-to-face or virtual and being able to provide job aids so that providers had ability to engage with the intervention flexibly, in a flexible way, and also providing emotional support for providers and parents was really key to this. Part of, just to kind of leave is that we did have some limitations, and Charlotte did speak a little bit to this, is that we did work in a challenging context. COVID-19 did affect how we implemented the intervention and as well some of the intervention exposure. The fidelity of the intended intervention. So we had to adapt. So we had planned for face-to-face, but ended up using mainly virtual Zoom meetings. And then there was limited intervention monitoring just due to the fact that we could not go to the facilities as we had initially planned. And so we also had to shift to a phone-based data collection. We spoke to most of our study participants through the phone, and we were not able to conduct observations. But we still see quite a few promising outcomes on that. So I would like to thank you for your time and hand it over to Elena, who's going to speak on the Respectful Maternity Care Charter. Thank you.
Thank you so much, Chantal, and hello, everyone. My name is Elena Ateva, and I'm an advocacy manager with White Ribbon Alliance. I'm also a human rights attorney. So today, I'll touch on the human rights aspects of respectful maternity care. We've already heard how critical respectful care is for healthcare, but it also is rooted in fundamental human rights. Next slide. Together with partners, we created the Respectful Maternity Care Charter, the universal rights of women and newborns. This was the first time that the rights of women and newborns was articulated together because we wanted to focus on the mother-baby dyad. It's critical, again, for their health, but it's critical to protect their rights as well. This document contains 10 rights. It was developed by a group of experts, and that includes professionals, M&H professionals, activists, human rights attorneys, provider associations, and colleagues from USAID, WHO, UNICEF, and the Office of the High Commissioner for Human Rights. The Charter doesn't include anything new in terms of rights. These are all rights that are present in different international instruments, so human rights conventions, for example, that have already been signed on to by the majority of countries. Next slide. And just an example, this is not an exhaustive list, but just an example of the types of human rights instruments we use to create the Charter. This includes the Universal Covenant, International Covenant on Civil and Political Rights, the Covenant on Economic, Social, and Cultural Rights, the Convention on Elimination of All Forms of Discrimination Against Women, and the Convention on the Rights of the Child, as well as some regional documents that we thought were very helpful. For the purposes of today's presentation, I will focus primarily on the Convention on the Rights of the Child as we talk about the rights of newborns and children. And I will only focus, in the interest of time, on 2 of the rights that are implicated in the Charter. But I'll share links to the full Charter, and I really encourage you to peruse it. It includes rights that are that both Charlotte and Chantal spoke about, that have been implicated throughout the their study, but are implicated in the care of newborns and children as well. So rights like privacy and confidentiality, respect and dignity, right not to be harmed. And so all of the rights are relevant, but we really only have time to maybe dive deeper into 2 rights. Next slide. Next. So the second right, as we have articulated it, is the right to information, informed consent, respect for choices and preferences, including companion of choice during maternity care, and refusal of medical procedures. And as many of you know, I noticed there's so many providers amongst you. The right to informed consent is really about providing free consent, providing information prior to the consent, and having the opportunity to refuse services and for that to be honored. Next slide, please. So this is the language from the convention. So I've indicated which article each of these citations comes from. But the Convention on the Rights of the Child talks about the responsibility really of parents. And the way parents are framed are also wider. So they talk about the extended family and community as well, to make decisions about the child, to help the child in realizing the rights as listed in the convention. And I've underlined here in a manner consistent with the evolving capacities of the child. And we're talking about very young children here, but still we should not forget that even from young age, children can be involved in their care. They can be asked about their likes and dislikes as soon as they're able to understand and respond. And they can also be told what's happening. So the right to receive information is really fundamental and starts very early on. It starts at birth. And the right for the views of the child to be given due weight. So it's really progressive. It's in accordance with their age and maturity. It's really important to reinforce bodily autonomy for children, because we know that as we do that, we keep them safe in any aspect of their life. Next slide, please. The European Convention on Human Rights in Biomedicine goes into more detail about what the right to informed consent means, and I've already listed that. So free, informed, prior includes information on the purpose of the intervention, as well as consequences and risks, and includes the right to withdraw consent at any time. Who makes decisions for newborns and young children? That is usually the parents, guardians, and if not, that might be an authorized representative. So it has to be indicated somewhere in national legislation who that representative is, who can make the decision instead of the parents if they're not present or for any other reason. Next slide, please. Next, I'll talk about the right of every child to be with their parents and guardian. So nobody is allowed to separate you from your newborn without your consent. You and your newborn have the right to remain together at all times, even if your newborn is born small, premature, or with medical conditions that require extra care. So this is really, really fundamental. Next slide, please. So the right, like I said, the fundamental right, Article 9 articulates it. States parties should ensure the child should not be separated from his or her parents against their will. And general comment 15, so general comments to conventions are usually articulations, authoritative articulations of what the articles of the convention mean. General comment 15 talks about maternal and newborn care. Following delivery should ensure no unnecessary separation of the mother from her child. So it's very clearly articulated. And further, it states that states should provide child-friendly health policies focused on training health workers to provide quality services in a way that minimizes fear, anxiety, and suffering of children and their families. And of course, again, that is primarily for very young children, it means to be with their parents. The Convention on the Rights of the Child is really, in its principles, articulates that the best environment for the child to be in, to grow up in, is within their family, where they can be loved, or where they can be happy. So for healthcare workers, the critical aspect to consider is, how do we support families? How do we support those parents within the healthcare setting, but beyond? How do we empower those parents so they can really fulfill their role as parents and support the child growing up? But Convention is very specific that this is the role of everybody, is to support the family, to support the parents, to take care of the child. And this is really the best environment for the child. Next slide. And so I shared that we have all of this information translated into the main UN languages. You have this available in very different formats for you to print, including to print if you want to display in a facility. We have large posters. Please peruse the information, and I'll share a link here in the chat so you can go directly and see what's available and what might be helpful to you. And I think I have one more slide with resources. Thank you. We have a podcast that you might find interesting that also dives deeper into each one of the individual rights, and you can hear more about it. Thank you so much. And I'll turn it over now to Felicitas to lead us into discussion.
Thank you very much, Elena, for your presentation. And thank you for 3 other presenters, Dr. Mwangi, Dr. Charlotte, and Chantel, for your presentations. And we're going to a Q&A session. And so far we have some questions in the chat box. Some of them have already been addressed by Dr. Charlotte, but for some of them, they have not been addressed. So I'm going to lead us in this session. So for Dr. Carol Mwangi, there was a question to you that was asking whether some of the guidelines that you mentioned to be available for newborn care in Kenya are available as open source. So you'll comment on that. And for Dr. Charlotte and Chantel, there's a question from Alexander about what was the study design for this study. You responded to the interventions that were given in the chat, but you didn't address the issue of what was the study design for this study that you've presented the findings to us today. There was a question about sharing the job aids, which has already been done in the chat box. The links to the various job aids have already been given. So we can start with those 2, address them before we get more questions. So I'll start off with Dr. Carol Mwangi. Are those guidelines available as open source?
Okay, thank you, Dr. Felicitas. A number of our guidelines are available on the Ministry of Health website in Kenya. That's the official Ministry of Health website. A few are being finalized, so they are not yet available. Thank you.
Thank you. And Dr. Charlotte and Chantel, what was the study design?
Hi, thanks, Alex, for the question. We used an implementation research approach, and it was basically a before and after. Well, that's what we had hoped. And then when COVID hit, so we did a baseline where we had the formative, so that gave us quite a lot of context, which was qualitative primarily. And then we did a baseline with providers and an end line with providers. And then we had a number of interviews with parents over a period of time. We weren't able to do so that was what we called a follow-up survey of parents. So primarily it was and then, as Chantal said, that we had a co-creation workshop to develop the actual interventions, and that was with the parents and providers and policymakers in separate workshops to come up with what would work. And then after the introduction of the training or mentoring approach. There was kind of each hospital decided on what they needed to do to be able to adapt the nurturing care framework and to improve their communication skills, etc. So that was a kind of iterative piece of work, and we had meetings over the period, the intervention period, in discussing how they're getting on, what they were doing, and how they were adapting to their particular facilities. So it was very much led from the facility, and then we did document what was happening along the way. We weren't able to give information around the piece on psychosocial support to the providers. We did measure burnout using the /burnout inventory among providers, and made sure that we were able to address some of those issues by organizing psychologists to attend group meetings with the providers. But that could be for another presentation another day. But there was quite a critical issue around how providers feel supported to then provide quality care. Chantal, do you want to add anything more?
No, I think you covered everything, Charlotte. Thanks.
Thank you, Dr. Charlotte. Another question is about the results. Maybe you can bring up the slide that shows the end line result, because Alexander had a concern that even in the end line survey, still the level of knowledge was just at about 50%. So I don't know whether you can bring back that slide that had the end line as we get the response from Chantel and Dr. Charlotte about, were they concerned that the level of knowledge during the end line survey was just at about 50%?
Well, yes, in many ways, but I think we started from quite a low, with quite low scores to begin with, but we did see significant improvements. And this, remember, we were doing this in during the pandemic, and so it was probably not top of their mind to be, they were also trying to manage all those other issues going on around them. So we were pleased that they were significant changes. We realized there's still more work to do. It's going in the right way, and there's the right trending in the right way. And we feel that there are promising practices. And I think that if we were able to replicate this in a more less pandemic setting, that we might see bigger improvements. I don't know, Dr. Wangi, whether you would like to comment on anything on what we found. Sorry, I didn't mean to bounce you.
Thank you, Dr. Charlotte, for that. The other question is about, it's to Elena about the Respectful Maternity Care Charter. So the question is, how can we get to operationalize the charter so that we go beyond just adopting these charters and actually operationalize them to include, to make sure it's actually being implemented, especially in the African countries, and adding the newborn to the chapter so that it's actually respectful maternal and newborn charter and not just the mother alone. Over to you, Elena.
Thank you for those questions. So I was starting to answer them in the chat box, but I appreciate the opportunity to expand further. For implementation of the Respectful Maternity Care Charter, we came up with a theory of change that really includes very specific inputs that need to happen. What we have seen so far, so those include on the provider side, ensuring that providers are supported, on the side of women and families, ensuring that women and families know their rights, that they are supported to demand those rights. But it also includes social accountability approaches to ensure improvements in systems. It includes the media and champions. We have found them to be very critical in ensuring respectful care. And sometimes it could include the whole environment, the legal and policy environment that needs to change. What we have found so far, countries, especially in Africa, are doing very well are adopting the charter, implementing through maybe Ministry of Health guidelines, or actually incorporating in QC processes, so checklists and similar. And we think this is very welcome, but it needs to, like I said, there are other elements that need to play into that. So, and there are different partners that, that work on those different elements. So ensuring that women know that they have the power, that these are their rights, that they can demand them, ensuring accountability processes at facility level that are working, where there's a continuous process of informing providers or facilities what's not working and how to make it better. Some of those issues need to be destigmatized, right? A lot of the abuse that happens is just so normalized. And this is where media and other, maybe theater and other things play a role to make sure everybody understands that this is not okay, that this shouldn't be happening. So I think we're still working towards this. On the second question, we had lengthy discussions, and some of the colleagues here have been part of those on the title of the charter. Maternity care without encompasses maternal and newborn. As we are starting to talk about child health, essentially, I think we have to consider as a community, do we need an expansion of this charter? Would it make sense to have a separate articulation? Of course, we have the Convention on the Rights of the Child, but would it make sense to have a document like this that is easier to read for women, for providers, that articulates the rights of children in healthcare facilities, for example? And I think that's a question for all of you, for the community to consider. What makes most sense? What would be helpful, essentially?
Thank you, Elena, for the response. For Dr. Mwangi, there was a question of what it takes for the African countries to adopt and implement some of these charters and guidelines that we get. So maybe from a Kenyan context, what will you say the Kenyan government has done so far in terms of implementing this? And another question about how to incorporate these guidelines in the pre-service training for midwives and doctors, so that by the time they finish the training, they already have the skills to be able to offer respectful and nurturing care for the mothers and the babies. Over to you.
So thank you for that question. So initially, Dr. Charlotte had asked a question as to why there was the sort of knowledge gap on nurturing care. And this is because the training of healthcare workers has not been done on a very wide scale. So and this forms part of the answer to the second question, how would we incorporate it into pre-service? That would be, we're in talks with our training colleges and universities to have at least an addition on nurturing care to the students in training at all levels, nurses and clinicians and also doctors. So the first question on what the government is doing to entrench this, as I'd earlier said, we're in the process of adapting the quality of care standards. We know respectful care is entrenched in the standards of quality of care for both the maternal, the newborn, the small and sick child, and the child and adolescent. So we envision that once finalized and incorporated into the Kenya quality model for health, and ours is the electronic version, it forms part of accreditation and assessment of facilities, such that a facility is assessed based, of course, on the level of care, but also based on the standards that include respectful care and preserving the rights of newborns and children. Thank you.
Thank you, Dr. Carol, for the response. And going back to Dr. Charlotte and Chantel, there was a question of whether the interventions included the use of provision of age-appropriate books to the children, and how different is this intervention different from like the family-centered care approach? How different was this? Over to you.
I did answer it just briefly in the chat box. We were not able to introduce age-appropriate books. I think we mainly just focused on, especially under the play aspect and interaction, was just mainly having children have these tactical play items and things that the providers actually had they made some dolls that they could introduce into the wards. Although I do note that it is important maybe for future, although we didn't really focus on age appropriate books. And in terms of the family care, yes, part of the literature review, family centered care did come up quite a bit, and we did include aspects of that into the intervention. So there's quite a bit of similarity in that. Thank you.
And just to add, in response to Sheila, comment about the difference between the NBU and the pediatric wards, I'm pretty sure it is around the health provider perception. And I think with nurturing care, as Chantal said, that it's people get it. And it was designed for primarily initially for the newborn units. And I think, again, it's down to the providers having so many, they're one provider per 30 children. So it's a lot more difficult. But I think we've seen a positive trend. And I think that we just need to do some more work at the pediatric unit to kind of encourage. I think there's a paper in the Lancet about using the nurturing care framework from 0 to 20 now. So I think we should build on the work that has been done by others. And from our study here, of a very small study in a very constrained setting, that we've seen some promising practices. And I think we can only build on this and take it further.
Thank you very much to all our panelists. We are coming to the end of our webinar, and I would like to take this time to thank all our panelists for that formative presentation. In case you asked a question and it has not been responded to through this panel discussion, we'll continue responding to the questions. We've captured them in the chat, and we'll be able to avail the responses to the remaining questions. But in the interest of time, I'd like to hand over to Patty to take us through the closing remarks. Over to you.
Thank you, Felicitas. Thank you, all participants and the presenters and moderators. This has been a very informative presentation and discussion, and rich and the questions that we have seen in the chat. On behalf of the Network for Improving Quality of Care for Maternal, Newborn and Child, and the Child Health Task Force, particularly the subgroup on quality of care, we give you thanks for this participation, for this rich discussion. You will find the slides, the recording and of the event, and the questions responses in the respective websites of the Child Health Task Force and the Quality of Care Network. And we hope that you will join us for the next webinars that we will be announcing. Thank you very much, and we close now.